We have differences in toxicity. We have differences in logistics that are not trivial.
How do you guide, your referrals that come in about what the best choice is, or even talking to patients?
Yeah, so I think as we talked about in TROPION-Breast02, it's relevant to talk about what toxicity looks like for ASCENT-03 and for Sacituzumab. And clinicians out there have a lot of experience with Sacituzumab, given its indications already in later line TNBC and hormone receptor positive disease. But what we're really seeing with Sacituzumab is primarily about 8% or so grade 3 diarrhea. We know even grade 2 diarrhea is clinically significant, so we need to keep that in mind as we're thinking about patient selection. And then neutropenia and cytopenia is a real concern. So in this trial, growth factor was not mandated, and there were some deaths on study, and those deaths were largely related to infection and neutropenia in patients who didn't really get growth factor support. So I do think we need to be sensitive to thinking about that sort of prophylaxis and protecting our patients.
So do you do that now? Forget the study, would you?
Right, so typically, and this is actually baked into recommendations now, that with Sacituzumab, I tend to use a long-acting growth factor on my day 8 to just help support my patient through their next cycle.
Exactly what we do.
Yeah.
So again, there are differences between these trials, including the schedule. So it sort of becomes individualized based on what a patient may be able to do or want. So how do you think about that?
I think that these are really shared decisions and decision making that we have with our patients. We have differences in toxicity. We have differences in logistics that are not trivial. It's a challenge, especially when patients are coming from a great distance to see their clinician or get to an infusion suite. 3 hours or 2 hours in an infusion chair is time away from doing something else.
Right.
So I think these are discussions that we have. The overall survival data is just really compelling and nice to see in the TROPION-Breast02 study. I think we have to give kudos to Gilead and the sponsors for ASCENT-03 to be able to offer and enable crossover so that patients are getting access to that post-ADC therapy. So I think the absence of seeing an overall survival difference there, it is perhaps a function of just the design of that trial, and that makes it a little bit difficult to compare. And we have to keep in mind these patient populations are so different too.
Yeah, I mean, we have this same conversation about the new endocrine agents and whether, you can compare. You're never supposed to put them side by side, and then we do it on a slide. So I think we always have to emphasize that, the composition of the trials was a little bit different. There are differences, subtle, but true differences.
With the TROPION-Breast02 trial, we saw almost 10% of patients having stable treated brain mets. So that's really enriched for, a difficult to treat patient population. We also saw in terms of PD-L1 status, TROPION-Breast02 had about 10% or so of patients that actually had PD-L1 positive tumors. And yet both of these trials are happening at a time when we weren't really seeing folks progressing off of KEYNOTE-522 and coming on to these trials. So only about 5% of folks had seen prior checkpoint inhibitor. So this is the space that we're in these days, which is so rewarding that we've got new drugs coming. It feels like there's new data to catch up on every couple of weeks these days. But the current standards of care are moving so quickly that we need to just extrapolate and make some assumptions because we don't have the big randomized trials to guide us in that regard.